Good afternoon. Thanks everybody for coming. This is an emerging issue in the state of Utah. Obviously, the Utah's medical cannabis program has been up here for since March 2020. We're going to talk about some of the basics of it. A similar presentation was given last year, but this year it's updated because the legislature has made some changes, and some of those changes have had some impact on those that recommend medical cannabis as medical providers in the state of Utah to qualifying patients. And so we'll talk about the basics of the program, and also we'll talk about some things that are going to change in the future with the program. And I'll spend about 50 minutes doing that. And then Dr. Marc Babitz will follow me, and he's a provider that has recommended medical cannabis in the past. He's also been the deputy director of the Utah Department of Health for multiple years in the past, and was my prior boss. So we're lucky enough to have him present on more of the clinical side and the history of use of cannabis. And so if there's questions about the laws or and the general infrastructure administration of the program in Utah, I'm the expert. If there's questions about the clinical side of things, Dr. Babitz is the expert because I'm not licensed as a doctor. So anyway, that kind of gives you some background. Also, one thing that's new about the Utah Department of Health is we're in the process of merging with the Utah Department of Human Services. And so we are now using a new logo that is the Utah Department of Health and Human Services. And it's an exciting merge that has some benefits for those that rely on services, both social services and health services from these two state agencies. And but in the end, there will be one agency formally created beginning July 1 of 2022, so in about 2 months or a month and a half. And with that, there will be the state's largest state agency of 6,000 employees that are able to coordinate together as we offer some health and social services to individuals in Utah. So anyway, that gives you a little bit of history, and the host would like you to unmute. Can you help me with that? Great. Okay. Okay, so the purpose of Utah's medical cannabis program is working with trained medical professionals, qualified patients receive access to safe and effective cannabis products that help them live healthy lives. In the end, that's the result we want as a program in Utah. This gives you a snapshot of what the distribution of medical cannabis looks like in the state of Utah. So as some of you may know, and if you don't, I'll tell you that there are types of cannabis that are federally legal, and there's types of cannabis that are federally illegal. And CBD and hemp, there's a lot of products out there. You'll be able to buy that at, many of you know, gas stations, at health food stores, at a lot of the grocery stores. A lot of CBD products out there, more and more we're seeing, right? Those are overseen by the Utah Department of Agriculture and Food. And some of you may already know, but as a reminder, there's a major difference between CBD or hemp products that you will typically see in like a tincture or a liquid form, and what we call medical cannabis products that have 0.3% or more concentration of THC, or tetrahydrocannabinol, that is the psychoactive property of marijuana when it's grown. Products with that percentage of medical cannabis, or that percentage of THC, excuse me, those are still federally illegal, but there's 38 states that have chosen to, like Utah, that have chosen to go ahead and make it state legal under strict circumstances. In Utah, those are strict circumstances. In other states like Nevada and Colorado and some others, as many of you know, they allow adult use, so not so strict. So in Utah, for those products that are THC 0.3% or more percent THC concentration, those are limited to be cultivated by 8 cultivators that are licensed by the Utah Department of Agriculture and Food. And then after it's cultivated, it also goes to an independent cannabis testing laboratory, a random sample of the products that are there. This is an important step. It's important that it's independent, so that way we know that this cultivator isn't just doing it all in-house and the laboratory testing and the cultivator in cahoots. That's not allowed in Utah. It has to be an independent testing laboratory. And there's actually only one license in the state of Utah to do it. And so all the product, they test the product, go through a list of tests. They keep records of those tests. And the results of those tests are reflected in what's called a certificate of analysis, a COA. And patients can obtain, or providers could obtain, a copy of those tests for specific products that are purchased. And so then it goes to a processor. There's also independent cannabis testing laboratory role there at the processor level. This kind of replaces the role that the FDA would play in testing products to ensure they're safe for consumption, to make sure that they have the level of THC or ingredient that they claim to have in the product. Also, they test the products for contaminants and microbials and ingredients that could be harmful to the health of the individuals that use the products as medicine. Okay, but I'll emphasize that this is one thing that makes Utah's program a bit unique when you compare it to other states, because in other states they're not required to go to an independent cannabis testing laboratory. They do testing, but sometimes there's not that independent relationship between the cultivator and the lab in other states. So we like to focus on that as one of the distinguishing features of Utah's program. So after it's processed, manufactured, we're going to talk about the dosage forms a little bit later that are allowed, but it then is sent to one of 14 medical cannabis pharmacies. In other states, the term used most commonly is dispensary. You might have seen those in Nevada or Arizona, surrounding states. They have hundreds of dispensaries. Utah's program, they wanted to reflect a medical approach, so they called it in the law a medical cannabis pharmacy, and that's how we classify it. We license 14 of them. That is something that the Department of Health and Human Services is responsible for, is licensing the medical cannabis pharmacies. The Utah Department of Ag and Food, they license the cultivators and processors. We license the medical cannabis pharmacies. So if a patient has an adverse reaction and they think maybe there was an ingredient that was faulty or harmful inside of a product that they purchased from one of the 14 medical cannabis pharmacies, they can file that complaint to our office, and we work with the Utah Department of Ag and Food and investigate that complaint. Okay, and then cannabis gets into the legal cannabis. I'll emphasize there's a lot of black market that still goes on, but legal medical cannabis, that is put into the hands of the patient in 2 different ways. So it could be picked up by the patient. That's most common. Medical cannabis card holder. You have to be a card holder to buy it. We'll talk about that in a minute. But they just walk into one of the 14 locations across the state and buy it in person. And then one of the things that happened after we'd already launched the program is that in 2021, we launched a delivery of medical cannabis throughout the state. Now, because it is still a federally illegal product, it can't be delivered by FedEx and UPS and the Postal Service. They won't deliver it. So what we do as a Department of Health and Human Services is we license the couriers that deliver it. So there's some companies that have stepped up and said, hey, we're going to make a business out of this. Let's go licensed by the state to deliver medical cannabis legally under state law. So medical cannabis courier delivers it to the medical cannabis cardholder's home. That happens in urban areas like Ogden and Salt Lake. It also happens to rural areas like Vernal and Price. Deliveries to Vernal and Price aren't as common. There's less population, obviously, less cardholders, but also the companies just specify certain days when they deliver instead of every day. So they list those options for patients. As a patient orders a product online, they would just select a certain day, and there's only certain days available for those deliveries, right? Because of the fact that couriers aren't delivering every single day in Blanding, right? It's only certain days of the week or certain days of the month. Okay. So one thing that is also a very critical part of our program is that there is an inventory control system. We bear in mind that this is still a federally illegal drug, and as such, there's a giant black market. And one thing we're concerned about that's happened in other states is that there's been a lot of excess product, excuse me, that has been diverted into the black market. In fact, in California, 70% of the cannabis there is black market cannabis, and it's bought every day illegally through the black market. In Utah, we don't want the same problem, but we know a black market exists. But to prevent the legal market from feeding the black market, we have an inventory control system where from 8 inches tall until patient sale, a inventory tracking system tracks that product. It also helps with any recalls. And that way we're able to say, okay, this individual bought some unprocessed flower. They've noticed that it has some very adverse effects that you wouldn't expect to have. There's a request to find out who manufactured that product, where was it cultivated. So they don't even just go to the processor level. They go up to the cultivator level and find out where it was cultivated at. And an inventory control system helps do that. There's a barcode on every package for every container that is purchased in the state of Utah, and that barcode connects with our inventory control system, and that way we're able to track it back if we need to. All right, that gives you a high-level idea of the distribution system in the state. Okay. Another critical part of the program is the qualifying conditions. So by far the most common qualifying condition with which people qualify for a medical cannabis card with is persistent pain. So this is defined as pain lasting longer than 2 weeks, and if it's not adequately managed despite treatment attempts with conventional medications. Then there's also HIV, Alzheimer's disease, ALS, cancer, persistent nausea under certain conditions, Crohn's, ulcerative colitis, epilepsy, debilitating seizures, MS, PTSD. That is the second most common condition. But there's a caveat with PTSD, and that is that it must have been treated by a licensed mental health therapist who's been diagnosed by either the VA or through an evaluation by a doctor-level psychiatrist, psychologist, LCSW, or APRN with psychiatric training. So it's not just any physician that could do that. It has to be one that has that training, that's able to evaluate and indeed have the expertise necessary to diagnose someone with PTSD. Okay. Some other conditions. Autism, that's one of the most common conditions that we find minors qualify with. There's a unique path that a minor must go through in order to receive a medical cannabis card. We'll talk about that a little bit later, but regardless, that's the condition there. Terminal illness with less than 6 months to live. We see a few of those. And then conditions resulting in the patient receiving hospice care. Things get a little complicated with that because hospice, like a hospice facility, many of them are federally funded, and many of them say, absolutely not. We are not going to allow a delivery or a patient to possess medical cannabis at this facility because it is still federally illegal, and our accreditation or our insurance attorneys tell us not to allow this, okay? But there are others who do allow it. So it would be just important that the patient or their caregiver, a son or daughter, whoever's kind of their agent, would confirm if they were at a hospice facility or an acute care facility that they'd be able to possess that there, okay? And then rare conditions. And then if an individual has a condition that is not a qualifying condition, then they may still submit a petition with help from their QMP to what's called the Compassionate Use Board. As an acronym, we call it the CUB. And there have been approximately 300 to 400 patients that have come through the CUB so far since the beginning of the program. And they review between 10 and 30 applications per month. This is a board comprised of physicians of different expertise, specialty backgrounds. There's a psychiatrist. Has to be at least 2 pediatric physicians. And so these individuals have some understanding of medical cannabis and its ability, in some cases, to have some decent outcomes for patients that have certain conditions. And so it's important that individuals that don't have a qualifying condition, if they still want to pursue it, that they connect with a provider that is willing to put their name on a petition and submit it to the board, and the board reviews those carefully. And one thing we see is that sometimes there just may not be enough evidence that, or sometimes there is, and the board approves it, but anyway. And then all patients under the age of 21, regardless of their medical condition, so even those with cancer or autism, still have to go through the Compassionate Use Board. Yeah. Yes. Mm-hmm. Cancer, autism, both qualifying conditions. Yeah, that's correct. The trigger is anyone under the age of 21. If you're over the age of 21, you don't have to go through the CUB if you have a qualifying condition. Yeah. Yeah. That's a good question. The question was, what is the turnaround time for a review by the Compassionate Use Board? So from the day the application is submitted online, and it's not on paper, it's submitted online in a secure portal, and to when the board would review it, statutorily, the statute requires that time frame not be longer than 90 days. So it's always going to be shorter than 90 days. Typical, I'd say, is 30 to 45, just depending upon when that application comes in. Also, a major factor in how quickly it goes through is whether the application is complete. And so there have been applications that have been submitted prematurely, and our staff at DHHS just has to reach back out and request additional information. And sometimes, so that impacts the time frame often. But I'd say 30 to 45 days for those applications that have everything in it at the beginning. And there's a mix of applications that come from providers that have done it many times. And after they've done it many times, they do a lot better job of submitting what is needed, right? And then there are those applications that come to the Cub that are brand new, and the provider maybe, it's more common for providers to maybe be missing something. We try as best we can to give providers a heads up about what's required, but sometimes there's things that are missed or whatever. So there's some back and forth. Those applications just naturally take longer. Yep. It's illegal to cross state lines. Yeah, right. Yeah, so there's good question. So the question was about federal highways. Is it acceptable for a courier to use federal highways within Utah for delivery? And up to this point, the feds have never stopped and made it an issue that there is a delivery of a medical cannabis federally illegal drug being delivered within a state. And I'm not an attorney, but I think there would be, there's legal reasons why they are hands off of that. But there are a ton, just so many purchases of Utah residents going to Nevada and coming back. I mean, that happens every day. And there's a reason why the Wendover dispensary is very busy. A lot of Utah license plates. So that's just naturally, that's been going on for years.
Does our card work at Wendover?
It does. But the problem is that when they bring it back into Utah, that product is illegal. Because Utah medical cannabis card holders, it's only legal for them to possess products that have been manufactured and grown in Utah. Yeah. Yep, that's kind of a little nuance about the law, but it's how it is.
So when you bring that in, is that a misdemeanor? Felony?
It depends on, I think, the volume of medical cannabis. The law enforcement would be the expert on how they prosecute it, but I think well, there's a difference between if there's evidence that it came across state lines, right? Because if it's crossing state lines, it's I think you get into some federal laws, obviously. Yeah.
So people using cannabis for recreational purpose, what's that THC level, so that I have an idea? Because
Good.
most of it is like less than 0.3.
Right. So if there is, yeah. So this is an important topic to bring up. I understand how these questions are obviously some of the most core questions that are important to get to. So I'm going to go ahead and address that now. So let's keep in mind there's the 0.3% or less concentration of THC that is federally legal, right, that you can buy at a lot of stores. And then there's the 0.3% or more THC products that are all federally illegal. A whole separate set of laws applies to those in the state of Utah. And often, well, how do you tell if a product is really 0.3% or less? You can trust the label, but sometimes you don't know what you're buying, right? What relationship does a customer typically have with a manufacturer of a CBD product they buy online or in a store? Zero. They just, It's the store that has a relationship, right? So if I'm law enforcement, and I suspect that a patient might be in possession of a federally illegal product, I would want to test that product. I'd have to in order to prosecute, right? So there's some testing that has to be done in order for, likely, in order for a certain jurisdiction to take action against a patient that's in illegal possession of medical cannabis. So those are some of the factors involved. Now, if there's evidence that they are possessing a THC concentration product that is higher than 0.3% concentration, then they've got to be able to demonstrate first that they are a active medical cannabis card holder, that they have not allowed their card to expire, that it's active because it requires renewal. We'll talk about that in a little bit. Also, they could have stole that product. Prosecutor may be interested in having them demonstrate that there was indeed a recommendation from a provider that that product was recommended to them, that their provider is a part of this possession of the medical cannabis, right? Because it could be that while they have a card, that they may not be legally possessing the product because they could have stolen it or gotten it off the black market. That's some game that some medical cannabis card holders unfortunately play, is they'll get the card, but they won't buy the product legally. Because there's a lot of reasons why people buy it off the black market, and one is they may think, and in many cases, they just can't afford legal market medical cannabis because you can't use insurance to help you buy it. You have to pay full price. It's not subsidized. So that is a major factor in a patient's choice to buy black market. That's just reality. I don't want to get too much into that topic, but that kind of gives you a general idea. Do you have any follow-up?
What I was trying to think was, like,
Yeah.
Remember the alcohol legal limit used to be 1.0, then it became 0.8, then 0.5,
Right.
then 0.05. And then if you get a patient with the alcohol level like 4.0, then you can put them on the totem pole where they are, how much intoxicated they are.
Mm-hmm.
So THC level in the black market marijuana or cannabis out there, is it operating at more than 5% THC?
Oh, yeah.
15%?
Oh, yeah.
Where are we?
Yeah. So, and okay, thanks for bringing me back to that core of your question. So, right now in the state of Utah, for legal medical cannabis, there is not a limit for the for what you can put in to a product. By concentration, there's not a limit, so you could have it even pure THC as a liquid suspension. Okay, that is legal in the state of Utah. Or the other restriction to be mindful about is what total amount of THC could someone possess at one time, right? And that limit is 20 grams, which if you think about 20 grams, that is a lot of THC. And you wouldn't find that in one product. It would be in, a bag full of products where you would add it all up. And the products that are sold have milligram of THC all added up, and it can't be a maximum of 20 grams of total THC combined, okay? So that gives you an idea for the legal limit in the medical cannabis market. Now, black market cannabis, it's going to have high levels of THC. But some of those levels of THC are going to be similar to what can be bought on the legal market because there's not a limit to the concentration that you can buy on the legal market of the THC. Does that make sense?
It could be 100%.
Mm-hmm. Yeah, and that is in my opinion, a concerning part of the law, and I think in many doctors' opinions.
We'll talk about that more and why
Yeah.
why it isn't usually
and there's reasons why it's not. If the person's using medicinally, it's not going to be in their idea. But there are a lot of people that buy legally in Utah's legal market that use recreationally. They were buying from the black market in the past, and now they got a legal card and they buy from a legal dispensary, but they're using, and we'll talk about some of those topics a little bit more later on. But that's a really good question, and we can visit it a little bit later on as well with Dr. Babitz too. Okay, so what are the requirements to be a recommending medical provider? Utah licensed MD, DOPA, APRN, or podiatrist with a controlled substance license. You have to be Utah licensed in order to recommend. So some physician in Maryland just can't do things virtually and never get licensed in Utah when he's meeting with Utah patients and recommending someone for a Utah card. Okay, and then in Utah, under that general requirement of that first bullet, there's two options. LMP, which is what we call limited medical provider, or QMP, qualified medical provider. An LMP may only treat their own patients with a maximum of 15, okay? So they can't recommend any licensed Utah provider of those classifications with a controlled substance license. Legally, they can, if they follow the correct, if they go through the correct process, recommend up to 15 of their patients without any additional training. We would hope they would do more, but you wouldn't be legally required to do additional training, okay? And then for limited medical providers, there's no CE requirement and no DHHS registration requirement. All right. So that was LMP. Now let's talk about the QMP. This is a Utah license, same bullet as the first one, but then we throw in you must complete at least 4 hours of DHHS approved education in medical cannabis during every 2-year renewal cycle. So you're doing an hour of that right now, and if you chose to become registered as a QMP, you could combine the 2 hours that you're doing now with 3 hours that you're doing online through an approved provider that we have on our website. And I know that adds up to a total of 5, but the CME provider that does it online, they only have a 3-hour option. So you'd technically be doing a total of 5 hours, and this would count as one for purposes of getting your QMP registration done. Okay. But if you're counting these hours towards like your DOPL license, then it's 5. It's just for purposes of your DHHS approved education that you'd have to do. The additional option is only the 3-hour additional course that's on our website. And if you want more information about that, you're welcome to email our office, and we can tell you more about that 3-hour option. So the 4-hour total education in medical cannabis during every 2-year renewal cycle, you must register with what's called the EVS. You do that online. Dr. Babitz has done that in the past, and there's a $100 registration fee. A maximum number of medical cannabis patients allowed for a QMP is 275, but then certain specialties that are listed there, if you have one of those specialties, you can recommend up to 600. Okay. And when I say specialties, I mean like American Board of Medical Specialties. That's the specialty we recognize for that. Yeah.
Am I to understand then for an LMP, you don't have to take any course or any tests?
No, you do not. Up to 15.
With the drug license can already do this?
Right. hmm it's brand new. We launched it in January. Um, there's a little under 200 providers that have done it so far. So out of 15,000, or actually 21,000 potentially licensed in Utah that could do it. There's a lot of people classified, as you know, as a physician, a DO, an APRN, or a PA, or a podiatrist. So total 21,000 plus of those. Of those, only 1 to 200 have actually taken advantage of the LMP. But we do presentations like this to educate providers. And of course, no one is ever obligated to recommend. If a patient requests it, of course a physician can always say, I just don't do those. Or they could say, my employer doesn't allow me to do that. Right? That's okay. But as a provider, I think it is good practice to be able to maybe acquaint your patient with another provider that maybe has more expertise in it. Like you do with other specialties, right? That's very common in medical practice. And in states, in the 38 states that have a legal medical program, that's something that providers are learning to do. And we just started in Utah, so something that is just becoming more common. Yeah.
Limit of 15, that means active patients? Like if someone stops treatment, you can add one more?
Yeah, so I'll define active as someone with an active medical cannabis card. So I haven't gone into detail about this yet, but cards last for 6 months. Initially, it was shorter, but the law changed, and they are now issued for a period of 6 months. Now, as a provider, you could choose to limit that period if you chose to 3 months, but by default, it's 6 months unless the provider emails us and says, I want this particular patient to have a shorter period. Okay. A limited medical provider, they could recommend to 15 patients and reach their maximum, but then patient 14, 6 months goes by and patient 14 decides not to renew. So if that happens, then someone could take that 14th slot, right? And then you're back up to 15 again.
So the cards are issued by a particular provider. They can't just go to another provider with that card. Is that correct?
That's a good point. So let's say I go to Dr. Babitz. He recommends medical cannabis to me. And the way that Dr. Babitz does that is he logs into a software that is run by the Department of Health and Human Services, protects all the information. He makes his recommendation. And with that recommendation, the Department of Health and Human Services takes that, documents it, issues a card via email. We send a PDF that has a barcode specific to that patient. Okay? That patient then can go purchase from 14 different medical cannabis pharmacies in the state of Utah, either online or in person. That patient may have a regular 3-month appointment with Dr. Babitz. Dr. Babitz can say, hey, as a condition of me taking you on as a patient, I want to meet with you every 3 months. The patient could say, no, I don't want to do that. And then the patient just goes somewhere else, right? And that just may be Dr. Babitz's condition on the only way I'm going to recommend this to you is if you come back in 3 months. So if the patient cancels their appointment, doesn't come back in 3 months, the provider has the authority to withdraw their recommendation at any time. So if the patient isn't meeting their part of the agreement to come back in 3 months, then doctor can go in and withdraw that. That's one option. Or initially, the doctor could actually contact us and say, hey, with this patient, I'd like the card only to be issued for 3 months. Okay? DHHS notes that. Card's issued for only 3 months. Then that card expires unless that provider comes in and issues renews the card for a longer period. Initially, when the program launched, believe it or not, the initial cards were only 30 days. And then law changed and they became 3 months. And then law changed and it became 6 months. So over time, Utah legislature and some providers have supported the concept of, hey, issue the cards for longer. If a provider feels uncomfortable with issuing a card for 6 months, then they can withdraw the card if the patient's abusing that relationship, you know, and not coming in for additional appointments.
So if the patient wants to go to somebody else during that 6-month time period,
Oh yeah, you can go to,
then do they contact the original patient?
they could, I mean,
Or
you don't have to. So, you know, at any time, if I went to Dr. Babitz, I could go to Dr. Oborn if I chose to during those 6 months. You know, if I just don't like meeting with Dr. Babitz again, but I can still purchase my medical cannabis under that initial recommendation that came from Dr. Babitz, you know, back in January, right? And then I say, I just want to go to somebody else. I go to somebody else, but I still can purchase under that recommendation. Does that make sense? Okay.
Yeah, I think part of the question he's saying is, like, you know, happens in our regular practices. If the patient comes to me for, say, Percocet, and I think it's a genuine reason, I give him Percocet, and then the patient goes to Marc over there, 2 weeks down the line, gets lower tab. I have no way of telling unless we run a Doppel check. But you guys are funneling it through one medical marijuana.
Yeah,
card,
good
so
point.
that's where-
Okay. Yeah, you're getting at that. Very good. Okay. Sorry, it took me a second. I'm going to explain first long term what the best way to address that is. Then there's a short term solution. The long term solution is that Utah law requires that the Department of Health work with the Controlled Substance Database and that we send our patient card information and patient purchase history of medical cannabis to the Controlled Substance Database. So any prescriber could go into the Controlled Substance Database like they can now and go to a module that is specific to medical cannabis purchases history and see what their patient has purchased in the past and confirm that whether the patient is an active medical cannabis card holder or not. Okay? Now that's only legal market cannabis. So if they're buying black market, then of course we have no clue. But that is the long-term solution. In the short term, you have to rely on the patient. To be honest with you, or actually a provider who is really concerned and has the time, they could reach out to us and submit a formal request, and Utah law requires that we be willing to disclose that information to a provider if they prove their patient-provider relationship to us. And so that is another option that they could that a provider would be able to take advantage of. Yeah.
So by long term, you mean this is something that they may do in the future?
No, it's already Utah law that allows it. It just, as you know, software changes take time, especially complex ones like this one. One reason why it's complicated is because is anybody familiar with NDC codes that relate to different medications that you prescribe? Each medication has a specific NDC code. You know, if it's Adderall or a narcotic or an opiate. And we need to be able to have NDC codes that correspond with each of the products that are sold in Utah's medical cannabis market. And the market is all over the place. A lot of different types of products that have different levels of THC and CBD. There's actually over 100 different potential compounds or properties within a typical marijuana product. And so a lot of different possibilities, and we want to be able to have that information shared in the software, but it's just a complex data conversion and project. So it's a project that we've started. It's anticipated that it could take up to a year to complete it. And once it's complete, we'll post information about it being complete on our website. We'll share information with this the Ogden Surgical Medical Society and also UMA and other societies, so prescribers know that, oh, okay, now you can go and find that information inside Utah's controlled substance database. It's just taking us some time to do that. So, and I'm being reminded that we need to make sure we do end on time, and part of that is me needing to move forward. So good questions, though. Okay. Medical cannabis card issuance period. We've already covered all this. This is why we took so long, right? So this just summarizes. Once a card is issued for 1 year, the recommending medical provider may specify approval for a 1-year renewal cycle. So I did tell you cards are issued for 6 months, but after 1 year, if with approval from the provider, they can indicate a request that the patient be allowed to have a 1-year renewal. Okay? Renewal visits may be done virtually, but that first visit requires a face-to-face in-person meeting. That is a unique part of our program. Yeah. So if someone is on hospice and they're homebound, if they don't have a medical cannabis card currently, how do they get a medical cannabis card? So providers do home visits, correct? Do you hospice doctor does a home visit? That's how it would need to happen. There has to be a face-to-face in-person meeting with the provider. So it seems to be maybe that's a concern, right?
Yeah, there are a lot of patients who, if you wanted to give them the appropriate drug and they were homebound,
Mm-hmm.
and you're an LM,
A limited medical provider that can do up to 15. Mm-hmm.
I mean, that's going to necessitate you going out to their house.
Right. Yes.
Well, that's true too.
Mm-hmm. Yeah, that's a good point. Right. Right. So for those online, the question was, it is some additional steps and more time for that provider to go visit a hospice patient in person, but it is something that is the standard for controlled substances anyway. So or C2s. So that in medical cannabis continues to be a controlled substance schedule of 1. Schedule 1 controlled substance. So, yeah. Okay. Good point. All right. I need to make sure I finish up on time to give Dr. Babitz sufficient time. So these slides are obviously going to be available to you after this. So you're welcome to go through them. And if you want additional information, you're welcome to reach out to the Department of Health and Human Services. Our contact information will be at the end. There are some things to just keep in mind. Just one, I guess, I think is just important to keep in mind on this slide is that if a QMP does not specify dosage type and or amount, this will be determined by the pharmacy medical provider at the medical cannabis pharmacy. So what we call a PMP, that most commonly it's a pharmacist. It has to either be a pharmacist or a physician at the medical cannabis pharmacy. A pharmacy cannot operate or be open for business without a licensed pharmacist who is present physically. So, as a provider, if you're only a limited medical provider, you may not feel comfortable making a specific recommendation about a type of medical cannabis product for your patient to have, right? Just may not want to do. Now, you may think, okay, I don't know, but I trust the pharmacist at the pharmacy, because the pharmacist at the pharmacy in Utah, they're a niche, what I call kind of a niche pharmacist. They are experts on the type of products their medical cannabis pharmacy sells. because they know what products they carry. They don't all carry the same ones, right? In a retail pharmacy, every pharmacy carries the same stuff, right? You know what you're getting. In this market of Utah, 100% of the product has to be grown in Utah, processed in Utah, sold in Utah. So it's Utah, it's unique. So the pharmacists are the expert, the medical expert about the specific products. Unless a provider does some homework, and providers can take tours and learn about specific pharmacies. But my point here is that a provider can, if they trust that that pharmacist will guide that patient correctly, they can not specify a specific limit on the THC. The state limit is 20 grams, but the provider could say, okay, I don't really know a lot about this, but I do feel like this may help this person with persistent pain. So I'm willing to put my name on a recommendation, but don't know enough to specify. I'll trust the patient and the pharmacist to work this out. So that's that concept there.
But does it mean a pharmacist compounds the material if you tell them so much, or is it just standard?
There's not compounding that happens. There could be in the future. But for now, that's too expensive for these pharmacies to want to worry about. What they do is some of these pharmacies are vertically integrated with their processor and with their cultivator. Okay, some of them are, some of them aren't, but some of them are. The one in Ogden is Perfect Earth Modern Apothecary, located here in Ogden. They are vertically integrated, and so their pharmacists are in a unique position to be experts in those products. Now, could be good, but I think some of you see the conflict of interest, right? If I'm a Perfect Earth pharmacist, and if I'm not careful about my conflict, am I going to want them to buy Perfect Earth products only, although I carry others? Yeah, I want them to buy my company's stuff. So I think that's a bit of a conflict. I wish the industry were better at complying with, but it's just natural in cannabis markets. The dispensaries across the United States and the pharmacies that sell medical cannabis in Utah legally, they have close relationships with the processors. It's not like your Walgreens, who very completely separate. These big manufacturers of narcotics and opiates don't. Typically, I don't believe they have relationships with the Walgreens and neighborhood pharmacies, although they buy a lot from them. Okay. Yeah. Not anymore. Initially they did, but not anymore. And as you know, likely the PA law changed, right? So PAs have more authority to operate independently as long as it's within their scope of practice, I believe, right? So when that law changed, it modified our situation with our law. Yeah, good point. Yeah. Okay, so when a QMP makes a recommendation, that can be modified in the future by a new QMP if they choose to. If the patient is just changing docs, that new provider can trump whatever that old one did. Mm-hmm. Oh, okay. Yep. So the pharmacist at the pharmacy cannot violate whatever parameters that provider has given. They can reach out and confirm, or they can have a conversation and say, hey, you did specify no vaping device or no vaping cartridge here, but I actually think as an expert on these things that this would actually be the best product. And then if the provider agrees, the pharmacist documents that and goes forward with selling that vaping cartridge to that patient. medically, not a lot of providers love vaping cartridges. I don't, but it may be, in some cases, the best option for treatment. Yeah.
I see a problem with this. In the unlikely event that the patient has an adverse reaction, who is responsible? Who is going to get sued? The doctor or the pharmacist? If the pharmacist prescribes the wrong amount or something, is the doctor now responsible for that?
Well, I'm not an attorney, and it would depend on the case. That's just my take, because there's certain liability that you would find also with, I think, in the regular Walgreens purchase of a medicine, right? You know, it depends on the facts of the case. Yeah. Okay. Dosage forms. There's a lot of like legal stuff. This talks about onset. That's what 113 grams looks like when you buy cannabis flower. This talks about the cub that we already talked about. Okay. This is a petition, what that looks like at the beginning. Here's the locations of the medical cannabis pharmacies. There's 7 on one column, locations, and then there's the additional 7, so 14 total. Yeah. Well, I mean, most card holders are located in urban areas, far majority, right? So no surprise there. There's over 50,000 medical cannabis card holders in the state today. Yeah. So Utah's program grew at a rate much quicker than other states. And there's reasons why. One is because cannabis had just had longer to circulate as an alternative medication. There's more studies out there. More people have more comfort with it now than 5 years ago, because of there's a lot of media attention to it. So people learn about it a lot quicker, and that's, we believe, one reason why it grew so fast in Utah. But it grew really fast, with 50,000 patients today, and so, and it continues to grow. It continues to grow by between 1,000 and 2,000 patients a month. Yeah. Yeah. In the back, sorry.
Since the dispensaries grow so much, the patient can shop, pharmacy can patient go from Salt Lake City to Ogden and get the.
Yes.
And how do you regulate? How do you know the patient shopping around?
So they're not. Yeah. So good question. So we have what's called the inventory control system that every pharmacy has access to, and what we call the electronic verification system, EVS, that tracks patient purchases and patient card status. So every pharmacist and pharmacy has access to both of those softwares. And our contract with our software provider requires that there be limits that the individual pharmacy agents and pharmacists can see within the software. So if I'm making a purchase in Ogden, that pharmacist in also Salt Lake can see that purchase as well. Now, 113 grams of unprocessed flower is a lot of flower. It costs a lot of money to buy that legally. So not a lot of patients reach their limits. Some do, but some don't. But that limit does exist, that ability. So it kind of operates similar to the controlled substance database in that way. Yeah, follow up.
So speaking of limit and the alcohol, the laws, you guys have way to do breath test for alcohol. Do you guys have similar testing?
We don't test for it as a Department of Health and Human Services. Law enforcement would test for that.
But you have device to test. Let's say you suspect that the patient do too much cannabis and driving on the road. Do you have cops that have the device to
the testing of cannabis is a lot more complicated than testing in THC level, is a lot more complicated than testing for alcohol. Law enforcement has methods for testing for it still, but it stays in the system a lot longer. And for me, it could be different than somebody else for how long it stays in my system. And Dr. Babitz can settle that.
The basic answer is that if you are arrested for driving erratically and you find any cannabis in your system or any cocaine or any oxycodone, you will be arrested and you'll get a ticket. There's no limit for those things. It's the driving erratically is what the stimulus for the police to stop you. So
Right.
Alcohol is the only drug that has a legal limit for it.
right.
Yeah, and there's, I don't, you need to, you could confirm with law enforcement, but I don't think there is an absolute legal limit for it in Utah. There is, I'll have to confirm that though. What's that? Yeah. Yep. And we do need to cruise over to Dr. Babitz's presentation, but I'll stick around for questions. Oh, yeah. Yeah. Yep, so that's our general number. Yep, and I'll pass this over to Dr. Babitz. And sorry I didn't have a chance to get over all the slides, but they'll be available to the group.
This is hard to do.
Ogden Surgical Medical Association. Okay.
You have a lot of good questions, so I'll try to go quickly to keep up with things. The next slide. So I am actually retired from the health department. The reason I put former deputy director is because when this law was enacted, I was the deputy director, and my boss said to me, Dr. Minor, said, Dr. Babitz, you're going to do this program. So we went ahead and hired good people like Rich and others to get the program together. But I went on a 1.5-year journey of studying cannabis intensely to learn about it, and I actually became a qualified medical provider because of my interest in it, and so we'll talk more about that. I still practice family medicine, a little clinic in Salt Lake, 2.5 days a week, limited. I have 45 patients who have recommended for cannabis, who I'm following. It's been very interesting. So some fun things. This is an old plant, right? You know this stuff. It's been around a long time. I love this last little bullet here. The people who wrote I had a great book. It was written by a couple of botanists who I think had anthropology interest in their background. They said cannabis, number one, was used for fiber, right? Hemp. Cannabis, the plant's great fiber. You pound the stems and it makes it, and they made everything out of cannabis fiber, you know, shoes and tents and so on. But the anthropologist said their theory was that when they were done pounding out and getting the fiber out, they put all the stuff in a big trash pile and they burned it. And one evening the wind changed and it blew back in their faces. And after that they were all really happy, and they said there might be some other benefit to cannabis after that. So that was one of their theories about cannabis as a medical thing. We talk about physiology, pathology, pharmacology. The real important things about some pharmacology issues. And this, when I get to the issues about pharmacology, why it concerns me about LMPs. LMPs have to know some really basic things to be safe with their patients. Again, indications, dosing, and so on. So the real secret person in all this stuff is a guy named Dr. Mechulam out of Israel. All the early research, all the best research has come out of Israel from that. Canada's done a lot of work on it, but the best still comes out of Israel. I could ask you, how many people in your medical school ever were taught about the endocannabinoid system? Nobody. I wasn't, because it wasn't discovered until 1990 by Dr. Mechulam, and really wasn't become more widely known until after that. It turns out that human beings have 2 cannabinoids we make in our body that are exactly like THC. We make 2 cannabinoids that are just like CBD. So they're endogenous. We have an endocannabinoid system. It's designed to work in certain organs. It's a balancing system. The THC analogs are agonists. The CBD analogs are antagonists. So it's like your nervous system, everything, you know, we have a balanced system, and it turns out we have the same for endocannabinoid system. Again, they're all over the place. I won't go into that. A lot of things that they do. But a lot of it's still to be researched and understood better. The receptors are pointing out there. There's the 2 that they mimic, the THC and the CBD, the MAMEs they talk about. The brain is the part that people are most interested in, I think, for several reasons, which we're going to get into, not the least of which is the psychological effects or adverse effects that we don't want to have. More receptor stuff. Okay, this was fun information. They had a patient, actually a couple of patients really, who were found to have a mutated enzyme that would not allow them to break down the anandamide, the THC analog in their system. These patients didn't feel pain. They had almost no pain. You could hardly get pain in them because they had an overload of THC stimulation in their system from their own endogenous cannabinoids. They also found people with certain neuropathies had a higher expression of the CB2, cannabinoid 2 sites. And we know people, especially from those who use it recreationally, that marijuana tends to really heighten sensations. They're really sensitive to sound and light and sound and taste and things like that. But for some patients, medically, that's an undesirable effect. So we'll talk about why you want to block that and how you can do that. CBD, you know about that. Again, it's an antagonist. It doesn't involve direct binding. There are a lot of drugs that will increase the availability of your endocannabinoids. The only CBD product that's a legal FDA one, right, about Epidiolex. And they recommend that you check liver function with Epidiolex if you're going to prescribe it. And I think there now are 3 different seizure disorders for Epidiolex. So they added tuberous sclerosis seizures as the third one that came up, which is good to do. A lot of people like to use creams and lotions and things like that, but these are very lipophilic. They're hard to penetrate the skin. You have to have some kind of agent to make it work well. CBD has no psychoactive effects, and that's probably why it was so easily made to be legal. Some evidence in rats that it reduces inflammation. The people will push CBD as an anti-inflammatory. It won't upset your stomach like other anti-inflammatories, but I think that's a questionable benefit of it, but we're hope to learn a lot more about that in the future. THC is the big one. Now, THC is the drug that people use recreationally to get high. People who want to get high want a product that has a very high percentage of THC because CBD is going to block some of the psychoactive effects, so that's a big issue. And the pharmacies, I don't know how much they're carrying of really high CBD or really high THC products, but for patients, make a recommendation. I really encourage them to make sure they have more of a balanced product. One of the issues about quantity of THC is it really easily to get this hyperemesis syndrome. More THC doesn't just make you higher and higher and feel better and better. After a while, you start vomiting your brains out. So it's not actually a good thing to have really high THC for that reason, too. Appetite, we know about the munchies from marijuana people talk about. THC is really effective for neuropathic pain. I've had amazing results with people with diabetes who have neuropathic pain, traumatic neuropathies. That's where I've seen the best benefit for my patients. I've had people with other kinds of chronic pain. I actually saw a man this week with severe osteoarthritis who no longer is taking opioids. He just loves his THC, and it really works well for him, and he doesn't get the psychoactive effects because he balances out with the CBD. So it varies on the person. Spasticity, again, often very helpful with a THC product. And again, the CBD can counteract the psychoactive effects. This is a biggie. I'm an old guy. When I went to medical school, we didn't know all these letters and numbers and stuff like that, right? So I just try to learn which drug is going to bother which drug. But the important thing is that it's that CYP3A4. That's a biggie. And both CBD and THC are metabolized there, and they inhibit that enzyme. And so that's going to be a problem by the inhibition of actually all these enzymes. And this is where there's some drug interactions that everybody should know about, including anybody who wants to be at LMP. So they're going to make the SSRIs, particularly they've studied Prozac, and they've studied, what other one I have up there? Sorry, I can't even read my own writing. Thank you. Zoloft and Prozac. They studied those two, and they definitely increase the concentration of that. You can have a patient get put into serotonin syndrome by being on antidepressant and then getting cannabis. So that's just to be aware of that. And again, the big difference if it's THC or CBD. It's both of those drugs will inhibit that enzyme that breaks that down. The most frightening drug interaction is patients on blood thinners. CBD and THC inhibit the enzymes that break down every kind of blood thinner, whether it's a direct oral anticoagulant or warfarin. And these patients will hemorrhage horribly. So again, that's what always scares me about the LMP if they haven't had training. You have a patient who has to be on a blood thinner because they had a DVT, and you recommend for cannabis, watch out. You're going to be in trouble, or they're going to be in trouble. Pardon? I didn't. Oh, aspirin. Yes, it will bother that a little bit too. They don't have, the anti-platelet drugs like Plavix and aspirin and NSAIDs aren't quite the same enzyme pathways, but there's still a concern about it. There's a concern about it. But the big ones are these other anticoagulants. I don't know the answer to that. I don't know which enzyme pathway was broken down, but I sure would be looking it up if I was going to have a patient on that and I knew they were taking cannabis. Yeah. They're supposed to, and that's actually, I tell you, I can have right now, I will tell you, I do not specify dosage, and I'll talk about method with a patient. I don't specify the dosage because not all pharmacies have all the different doses, and because the pharmacists I've met at these pharmacies are outstanding. First of all, they're real pharmacists. They know about medications and drugs. And when I submit my information on a patient, I submit their full drug list, everything they're taking. So the pharmacist knows that. So that pharmacist knows about what they're taking plus what the effect of their cannabis is going to be. And that's really important. But I really worry about at LMP, if they had somebody particularly on any of these SSRIs or blood thinners, if the pharmacist doesn't catch it, there's going to be a real problem. So we hope they do. But I think the LMP, we have a responsibility also here. You know, it's not like I have no responsibility, just give it to the pharmacist to fix for me, right? So be aware of that. Anyway, those are the biggies, I think, for interactions I would want to share with you. You know the different reasons why we recommend medical cannabis. The one I want to point out is this is back in 2018. NIH, National Academy of Sciences, published a huge study. They pulled out like 30,000 different studies around the world on cannabis. They threw out about half of them as not being large enough or valid enough or things like that. And they went through over 10,000 studies. And based on that, they came up with a list of things they felt cannabis could be justified as valuable for use. And it does pretty much mirror what Utah chose to be the legal ways to do it, but to use it for. We've talked about some of those things already. I won't read that list. You already read it. CBD is the biggest one. Actually, it helps with sleep, not the THC. So people can buy that on their own if they want. Notice that there's limited evidence for appetite and weight gain, like for HIV patients. And PTSD, by the way, cannabis does not cure PTSD. That's a misnomer people have in their mind. If I have a patient with PTSD, what I say to them, cannabis may help some of your anxiety and your bad dreams and your flashbacks, things like that. It's not going to cure you, and you need to be staying with your mental health therapist. You need to be in therapy, because that's how you treat PTSD. Not cannabis is a magic bullet for that. And again, that's why it has to require a mental health professional to certify along with me.
There was an article last month in Pain Management that says the opposite. It's highly effective for sleep, ineffective for spasms, and ineffective for pain.
Yeah, I totally disagree with that based on lots of evidence and many studies.
It's a journal like that, it has some credibility.
Yeah, it does. I don't know what they were citing for their studies, because there's so many would say just the opposite. And again, the National Academy of Sciences came out and said for pain, yeah, especially for chronic pain.
When you say cannabis, are we talking CBD or THC?
It's going to be both. Now, again, I'm going to emphasize for pain and spasm, THC is the main ingredient that's going to make the difference. For relaxation and anxiety and sleeping, CBD is probably the more important ingredient. Most patients find they want to have a balance, want both. If I have somebody with pain or muscle spasm, I'm telling them, you need to have a good concentration of CBD if you want to avoid I call it the fuzzy brain or the foggy brain, the psychoactive effects. And that ratio could be anywhere from 50-50, maybe as high as 60-40, maybe even 70-30 on the THC side, but definitely not higher than that, percentage-wise.
So 113 grams of unprocessed flour will have both.
It depends on the flower. So I think I have a little bit later. We'll talk about the differences in the plant and the flowers.
Somebody's titrating the proportion or ratio of CBD versus THC.
Well, the products have to be labeled by milligram content. That's what I really care about. In fact, I know from one study that I looked at that says that for pain control, the most THC anybody should be taking in a day is 30 milligrams. 30 milligrams a day is the recommended maximum. So if I follow somebody and they're actually on more than that, it makes me concerned that they're doing recreational cannabis, not for pain control. But they need to balance with CBD.
A question about anxiety and PTSD. I'm just curious why PTSD is a qualifying medical condition, but anxiety is not. That's one question. The other is why, as a family practice doctor, I'm not considered qualified to diagnose PTSD.
Yeah, I'm family practice too, so I'm with you on that. Well, why is PTSD in there? It's the politics. It's the citizenry. It was one of the ones that was in the initiative that they wanted to do that. That was, people really wanted it. As Rich was saying, it's like the #2 most commonly prescribed cause. And it doesn't make sense to me. Depression and anxiety. Depression, I'm glad is not in there. Anxiety, I would say, yeah, that's the symptom that they're treating with that. And in fact, the severely autistic children who get approved by the CUB for cannabis is to control their outbursts, their anxiety, their screaming and yelling and behavior control. It does behavior control. Obviously, it doesn't treat autism, but it does behavior control. So I agree with you. I don't know. It's just all politics. They got PTSD in the list and not anxiety. And what was the one last year, Rich? They passed. Somebody wanted to add another condition last year. Pain, was it? Oh, acute pain. Yeah, and that's interesting. Again, it was just a politician with the public. There's no evidence that it works for acute pain. There's none. So why they would do that? But what can I say about when the legislature gets involved in healthcare? Watch out, right? I mean, that's the general rule. And then no evidence except for the epilepsy ones, we know about that, but people use these for these things. The opiate addiction is interesting. Does cannabis treat opiate addiction? And actually, a study out of Colorado where they were giving cannabis to people on opioids, they found an interesting thing. 1/3 of the patients wanted both drugs. They wanted cannabis and opioids. 1/3 said, I don't like the cannabis, I'll stay with my opioids. And 1/3 said, okay, I'll decrease my opioids, but I still want my cannabis. So, this is up in the air. Does it really change opioid addiction? Probably not. It's not recommended as a treatment for opioid addiction per se. And I can say, I can just say anecdotally, I probably name 2 patients when I saw it this week, 2 patients who have really given up opioids for cannabis. That's out of 45. Now, 80% of my patients are chronic pain patients. So whatever that is, 2 out of 30 some, that it worked on. The other one's still maybe a little decrease in their pain medicine, but they're still doing both. I think the thing that I like about the cannabis for the patient is to say, I'm not increasing your opioids. I'm not giving you more opioids. I'm sorry, as long as you're functional, you don't get any more opioids. But if you want to try something to help you, then I would suggest you consider cannabis, and we'll talk about that. But we're not going to do more opioids. Yes?
Are the indications the same from state to state? Are they different?
Very similar. Very similar in most states. You'll find things like anxiety in some states, but they're generally very similar. Just for fun, trivial pursuit. What state in the United States has the most dispensaries and the most highest percentage of cannabis card holders? Oklahoma. Oklahoma has over 2,000 cannabis dispensaries, and over 10% of the population has a cannabis card. I couldn't believe it. Pardon? Yeah. I think it's indicated for tornadoes in Oklahoma is why they have them. Yeah. Yes, sir. Oh, no. It can definitely be a first line. If someone was coming to you if somebody was new to me with neuropathy or a diabetic who is now starting to get neuropathy, I would probably try cannabis before I did, gabapentin or Lyric or something like that. I would talk to them about the cannabis, see what they wanted to do. And I would encourage them to try that first, actually. So it's your choice medically. What I found, I never, you asked me 5 years ago, was I going to recommend cannabis to patients? I would have said, no way. I'm retiring pretty soon. I'm not going to be doing that. But after studying it for a couple of years, I became convinced that like any other drug we use has benefits and risks. Cannabis is no worse than anything else I prescribe, frankly. I just have to understand it, like other drugs. And the thing I like about Utah is this requirement for milligram content. Because I want to know how many milligrams the patient is taking. I want to know if they get over above that 30 milligrams, for example, a day for pain. Because milligrams are actually important to me. I mean, we all prescribe things by milligram content, too. I joked with a patient the other day. I said, can you imagine me telling you have a strep throat, and I want you to go home and eat 3 slices of blue moldy bread every day? Well, there's penicillin in there. Don't you want to do that? No, I want the pill. Well, that's what I'm doing with cannabis. I want to put it in a form that I can measure what's in there so I know what you're actually getting. And none of this stuff about, well, I need this flower or that flower. Let me digress now because I did want to talk about the fact of growing. The marijuana plant is highly sensitive to growing conditions. Temperature, light, humidity, amount of water, amount of fertilizer it gets, things like that. And that means that cannabis will be very different when grown in different conditions. Patients who get into recreational cannabis like to go by these fancy names, right? Purple haze, candy cane, birthday cake, August rush. There's these names. And somebody said, well, I was in Southern California and I found that August rush was just right for me, did just what I needed for my pain or my whatever it was. And I say, that's great, but that's meaningless. What was in your August rush? I have no idea. How many milligrams of THC, CBD, what was in there? And by the way, if we grow that August rush brand of cannabis in Utah, this can be totally different. I can't duplicate the growing conditions from California, light, humidity, fertilizer, temperature, and so on. When I visited some indoor growers here in Utah, it was fascinating to see the indoor growing facilities because they're sealed rooms. You got to put on a surgical gown to go in the room. They're sealed rooms. And they control the humidity, they control the temperature, they control how many hours of light the plant gets, they're controlling the water, fertilizer. It's amazing. And the botanists who run those growers, they have learned if you adjust certain things, you increase certain ingredients in the plant, in the flower, so they can produce more of this or that, which the processors want to do it. So again, I want to prescribe things by milligram content. I'm not going by some fancy name. I know when we met with the growers years ago to talk about the requirement of labeling milligrams, they were all resistant. They really love their names. You know, Purple Haze, August Rush, Birthday Cake. And we said, look, if you want, after you put the milligram content in small letters, you can write the brand, the strain name from the plant, just for fun. But other than that, I don't really care about it. Also, there's some, I'm going to call them the old terms. You probably heard these old terms. Sativa, indica, hybrid, and so on. So sativa was the higher THC plant, the tall, skinny plant, and indica was the short, stubby plant, more for relaxation. What does that mean? It means the sativa plants had higher THC and the stubby little plants had higher CBD. That's all it means. But those don't work anymore. We're dealing with hybrids, hundreds of hybrids. They're all mixing this and that to get different combinations. So you can't even go by that name anymore. I tell people, don't even worry about that anymore. What we care about, like any other medicine, is how many milligrams is in the product that you're using. And that's what I want to know, and I want to work with you on how many milligrams you're doing. Okay, some major contraindications and why that is, and why is the cub under 21? Cannabis harms the brain. Cannabis causes brain damage. If a pregnant woman uses cannabis for her pregnancy, her baby will have lost a whole bunch of IQ points and maybe worse when the baby's born. If that mother keeps using cannabis in the house, the baby's exposed to it, the baby's going to have even more problems. You give cannabis, even medicinal cannabis, to a child while they're growing up, they're going to have brain problems. A growing brain is harmed by cannabis. And that was actually one of the big reasons for the outrage against the initiative. I was against the initiative, when the public initiative, because kids would have had access to cannabis. And that's really dangerous. Cannabis has also been shown, documented pretty well, that in teenagers, cannabis will bring out schizophrenia. Whether it causes it or not, it's not sure, but it'll bring out schizophrenia, another dangerous thing for young people. That's why the cub came into effect in Utah. They said, we're not going to allow it under 21. The folks I worked with who were really involved with harm from cannabis in children, they said the age should be 25. They said your brain grows till you're 25. But state legislators, in all their wisdom, 21 is the age. Cannabis will cause increased heart rate and can lower your blood pressure. Well, if you already have angina or you're already borderline heart failure, that's going to be a real problem. So we want to know how people's heart function is. And then people who have respiratory problems, if they're going to choose to vape, that could be a concern. I will say that the pure THC cartridges used for vaping have never, that I know of, been linked with the vaping problem of the lungs, because they're pure. You probably know this, but the vaping problem came from that vitamin E oil. That was the illegal product in the black market cartridges people were using. Another trivial thing. I asked people, why vitamin E oil? And the cannabis folks says, because it passes the bubble test. If you take a cannabis cartridge of THC, there'll be a little air in the top of it, and you turn it upside down, the bubble's going to rise through the oil, right? Turns out the people who faked cannabis, they figured out that vitamin E oil had the same rise as the bubble, as real THC cartridge. And that's what they did, because people out in the street were saying, let's see how fast it goes up. And they know if it was the real thing or not. Well, it wasn't. But legitimate, legal, approved cannabis cartridges are not a problem unless you already have underlying disease. Vaping cartridges, I'm not a big fan of it. If people want to do it, I do that. But as Rich said, there are these little units you can buy that will heat it up and vape. Now, when it comes to smoking, it is illegal in Utah. Doesn't mean people won't do it. But I tell patients, look, I'm not the policeman. If you smoke, it's up to you. But I'll tell you what you're going to do if you smoke. You're wasting 20% of your money, because burning is about twice as hot as vaping, and it will destroy 20% of the cannabinoids in your product. So all of a sudden, you just lost 20% of the stuff you just paid for. Vaping, at about 200 degrees, you get all the cannabinoids. You don't lose anything. So vaping is better that way. Plus, when you burn, you get the net negative tars and stuff you get from burning any plant material into your lungs, which is also bad. For patients who choose to vape, if they only need to vape once or twice a day, and vaping is a rapid onset of relief, it only lasts a couple hours, that works for them, that's fine. But if somebody's vaping every 2 hours, all day long, I tell them, look, you need to convert over to an oral dose where you're going to eat it, or a gummy or a tablet, because oral cannabis may take 2 hours for the first dose to work. Then it's going to last 8 hours. And if you were to take your dose every 8 hours after that, you're covered all day long, and you have the same benefit. In fact, as I tell people, you can have the pharmacist work with you. You have them help you figure out how many milligrams of your THC CBD you're getting with your vape, and how many times you do it over the day. Then have them convert that into an oral product for you, so you can get the longer acting relief and not have the problem of vaping.
Are the anti-inflammatory effects severe enough in cannabis to affect biologics?
The evidence isn't good enough for that. I mean, anecdotally, people will tell you, "Oh yeah, it's great," but there's no evidence for it. It's just anecdotal people, and so I don't buy it. I think they're hoping to find more. By the way, when I first started researching this, there were 114 distinct cannabinoids in a cannabis plant. Now they have 120, up to 120. Many of those are THC analogs. The other ones are CBD analogs. A lot of the things like terpenes, the things that give flavor and smell, are in the cannabis plant. So it's full of chemicals. It's just a loaded plant, which was actually kind of amazing. Dr. Matulam actually said that when you have patients who are using a purified THC CBD product, and most of our capsules and tablets are just THC CBD, if they're not doing really well, they actually might need the whole plant. He called it the entourage effect. I love that name. You need the entourage effect. And that actually turns out to be true. A lot of patients, if you're not doing well on your spray or your tablet, just THC CBD, and you're going to have to buy the flower. Whether you vape it or eat it, it's up to you. But when you buy the flower, you get the whole 9 yards. They use terms like broad spectrum or full spectrum to refer. Broad spectrum is many things, full spectrum is everything, versus just the purified THC CBD. Depends on the patient, how it works. What else I want to tell you about? Okay, it's a controlled drug, so you are going to do everything you do. Look at medical records. You've got to do good history and physical. History is really important in terms of past medical illnesses like mental illness, if drug abuse problems in the past, we want to know about that. Cardiac problems, respiratory problems, know about those things. You got to check this. You got to check the controlled substance database. Again, ironically, if I'm a QMP, I have to do that. LMPs don't say they have to do that, but they should, right? But kind of weird. Follow-up, again, Rich sort of mentioned, we decide what the follow-up care is. Obviously going to document. The EVS right now doesn't seem to require me to put a note in the chart when I submit a name for recommending cannabis. I always do. I always put my I put my whole thing in the chart for the patient because I want the pharmacist to have everything that I know. Patient's problem list, patient's medication list, past history, family history. I want the pharmacist to know all the things that I know so they can help with the patient choosing what they want. But it's not required. I don't know why that is, but they don't require it. And then I may have to be working with other providers sometimes.
So since you're sharing that medical information, do you have your client sign a release of information since it's going to be used in the pharmacy?
No, although they do tell them that this is going to go into the EVS, electronic verification system. So I mean, that's a good question actually. I consider their desire to have me recommend them medical cannabis their permission to do whatever I have to do so they can get a cannabis card. And putting things in the EVS is how I do that. That's a good question. I probably should be more specific. I should probably do something and say, I do tell them I'm going to be putting these things in when I recommend you, but that's a good question.
What is the EVS?
I'm sorry, Electronic Verification System. It's this massive software program that the state has. It was a huge job by Rich and his team to get this thing put together to track all this. It tracks everything. Tracks the plants, tracks the processors, tracks the growers. It tracks the patients. It's a huge, complicated system. That's why I was saying it'll take a year possibly to add cannabis in, as part of the controlled substance database to get the EVS to talk to the controlled substance database. Just a massive system. Yeah.
Does medical cannabis affect the or contraindicating patient with hypogonadism, or does it affect with the toxic?
I'm sorry, say with,
Testosterone level, does medical
toxic level?
Hypogonadism.
Oh, I'm sorry. Cannabis, medical cannabis, just cannabis in general, will decrease sperm count. It'll do that for anybody, whether they have hypogonadism or not. So that would be a double whammy if you already had that kind of thing. So that will happen.
So you've had 47 patients in your practice. If I get somebody with diabetic neuropathy, I know where to start. I'll start like, Neurontin 100 TID, and if it doesn't get better in 2 weeks, maybe 300 TID or 600. So do you have a feel like, THC 1 milligram BID, or what's your...
Yeah. Now again, so I'm trusting the pharmacist actually to help me do that. But I'll tell the patient, look, you probably are going to start at 1 milligram of THC, and I want you to balance it. Talk to the pharmacy. Maybe you have 1 milligram, so a 50-50 mixture, or maybe it's 1.5. So it's that. I want it balanced. But if they've never used cannabis before, 1 milligram is a good place to start. And I said you can increase it every 2 or 3 days actually to see how it works. That's maybe the benefit of a vaping pen. If I know that, just for example, if one puff on a vape pen is 1 milligram, I take 1 milligram, I wait 90 seconds, I know how it works. Take another puff, 90 seconds, now, oh, it takes 2 puffs to work. So I figured I know it really quickly, actually faster than that first gabapentin dose would work. So I can do it that way. Then that patient, I'm going to ask them to work with the pharmacist to convert that vaping over to an oral dose. But I would start, people who are so-called cannabis naive, I start like just 1 or 2 milligrams at any given dose, whether it's vaping or drops orally. If they want to start with capsules or gummies, an oral one, probably go a little bit higher. You lose on what's called first pass metabolism, you lose some of the cannabis effect, so they might start at 2 or 3 milligrams. You have some patients come to you and say, Doc, I've been using cannabis for 5 years. So I've done this. Now they have no idea what the dose is. They really like August Rush. I say, well, that doesn't help me at all. So I say, okay, you may want to start, talk to the pharmacist, you may want to start 4, 5, 6 milligrams. But I'll tell you, I don't want you going over 30 milligrams a day. That's my maximum, and I'll tell the pharmacist I have to. And I don't have anybody that's gotten to that level that I know of.
And there's no sublingual formulation?
There are sublingual ones. They have drops and liquid and things like that, sprays. You have to choose one. So they're actually, that's what Rich is saying, all these products. You could have an oral spray they have 20 different ones, ranging from 90% THC, 10 CBD, all the way around to 1090. It's really frustrating because each preparation could have multiple ways of doing it. I think it was, Rich, where did you guys go? Minnesota was where they have the color-coded. In Minnesota, they only allow like 6 different ratios between THC, CBD, and whatever package you have, whether it's pills, capsules, liquid, or spray, has to have a color code. So if you buy a purple product, what product it is, it's 90-10. You buy the green product, it's 1090. I mean, they're really clever. They've limited it to only 6 different options, and so it's actually kind of a clever system. We haven't done that.
So if somebody's doing cognitive work and they want to keep working, but they have chronic pain and fatigue, would you recommend a 50-50 to balance out the cognitive?
I would definitely have them start with a 50-50. I said if the pharmacy doesn't have that for you, then maybe you could try a 60-40. But you want a strong CBD component because that will block the psychoactive effects. I also tell cannabis patients, when you're going to start this, please start, assuming you don't work on Saturday or Sunday, please try it on the weekend first to see how it affects you. Cannabis can be a little bit sedating initially, like you get a little bit tired or you feel like relaxed kind of thing. So see how much it affects you. And if it's going to affect your driving or things. And you have to we always give the warnings, right? Be careful about driving. Be careful about taking it with alcohol or any other drug that might be sedating. But I tell people, start over the weekend when you're not too worried about what's going on before you go to work and do that. Don't want to be falling over your desk at work. Yeah. Yes, sir. Not for the physician. There's no liability for the physician. A patient has a liability. If a patient is found to be doing something erratic, driving a car or operating machinery, whatever, erratic, and they have cannabis in their system, they are going to be charged with a DUI. And as I said before, there's no level. It's not like the alcohol, we have to be above the 0.04. There's not a level for cannabis. They just have to test for it. So, and like Rich was saying, it stays around for a long time. So if the patient had used it a week ago, they may still get a DUI for driving erratically. Yeah.
What about trucking companies and sports organizations that do drug testing? So a person hasn't driven erratically, he doesn't have a DUI, but comes up with a positive on a urine drug screen. What's the implication for them?
I will try to ask patients, like with the patients who are working with, like, what does your employer think about using medical cannabis? I had one guy the other day just said, my employer is fine as long as I have a card. And we do test it. If he tests me at work and I have a card, I'm okay. But if I don't have a card, I mean, what would your employer do if you tested positive for opioids, for example, this kind of thing. So it depends on the employer, but every employer has the right to have their own rules on that. An employer can say, I'm not hiring people who use cannabis. That's their right to do that. I don't hire people who use opioids if they wanted to say that too, for that matter.
And just
Yeah.
to add on that really
Sorry.
quick, Dr. Babitz, the Utah law does say that if it's a public employer, that they need to treat it exactly like they do opiates. completely separate. The state law is very clear that that private employer has the choice to discipline them or to not hire them based solely on the fact that they have a medical cannabis card and that they know that they're consuming cannabis, but they test positive of medical cannabis. So a private employer would require that as a condition of employment that they sign a statement that they don't consume federally illegal drugs, including medical cannabis.
Sorry, can you speak by the microphone?
Oh, yeah, sorry.
So the point was being made is that public employers are required to give people the option. They can't prohibit it, but private employers can't prohibit or have people sign agreements.
You don't get a CDL if you test positive for marijuana because it's a federal regulation.
Or any of the drugs, any of the controlled drugs.
Right.
I'm just talking
Oh.
about marijuana. You cannot get a CDL license.
So the comment made is you can't get a commercial driver's license if you test positive for marijuana. Yeah, thank you.
Same with law enforcement, post.
So law enforcement people have to do post-training. Question in the back.
So, marijuana was considered for a long time to be a gatekeeper drug.
Gateway drug. Gateway.
Gateway drug. Yeah. And so is this seen as a problem now that there's legal marijuana use? As people are using legal marijuana, they are moving into other drugs, either abusing legal drugs or using illegal drugs.
Not to my knowledge. Have we seen that in any of the states that do that? And the reason is really it has to do with THC. So the gateway drug, if you will, marijuana is THC. And the people who would abuse it were looking for the really high THC with no CBD, frankly. And they just wanted to get high and do that and fall asleep or do funny things or whatever. And so that in that sense, a drug like that has such major mind-altering effects, would people want to do other drugs like that? Yeah, that was why it was considered a gateway drug, and probably that's true. But when we're doing medicinal marijuana, medicinal cannabis, especially where I'm telling people you want to have a balanced product, we're avoiding that. And patients, most of the patients I have, they actually tell me they don't want that. Doctor, I'm afraid I'm going to get kind of fuzzy-brained. I said, well, that's how you prevent it, is with enough CBD. So it's not going to get them to want to do any other drug particularly. So it's been beneficial. In that way, it's so much, cannabis, it just, in my mind, it just isn't different than all the other drugs we prescribe. Is putting somebody on oxycodone a gateway drug? Maybe, they have a bad fracture and injury and they have bad pain and they need pain relief. Do I just ignore that, or do I give them oxycodone? There's a chance that when I stop oxycodone, they're going to go to heroin. I mean, so it's an interesting question, but it applies to so many of the medicines that we use where that's a concern. So I think medical cannabis used appropriately, I think has real benefit and is not a gateway drug. A good reason also why we don't give it to kids, because kids are going to want, their goal is to abuse it, and there's also risks for them. They're more likely to get, the brain development, so on problems. I'm sorry, you have a question? Trying to.
Just go back. So with the controlled substance database, the notation is to check the EVS, or does it actually state that if you see
When you've probably seen this now. When you look at this controlled substance database, there's a little column on the right that says EVS, and it's just telling you that. Well, Rich might know. It's telling you. I assume it tells you that patients on cannabis. If it says EVS, does it mean they're on cannabis, or just a reminder to check the EVS? Do you know? Come.
Not that tab is there as something that is for the future.
Oh,
It actually doesn't
okay.
provide any information yet.
Okay.
They just put it there as a placeholder, and in the future, though, it will.
So not yet, but
No.
so if you click on it, you don't get anything, I guess. So yeah, but it will be soon. Yeah. No, and that's a problem because it's very expensive. It really varies by the pharmacy, and that's where having a good, honest pharmacist to talk with you about different choices. I can tell you that vaping that's a more expensive way with cartridges, and some of the ones that are compounded like tablets or things can be more expensive. Theoretically, the flower should be the cheapest because it doesn't require any processing, and they just know what it is. And I mean, I can tell a patient, if you buy this flower and they tell you this flower has 30 milligrams of THC and 30 milligrams of CBD, and you only need 2 milligrams at a time, you're going to have to grind that up, and you're going to have to separate it in little piles, and you're going to have to take a little bit and sprinkle it on your soup or put it on your brownie or whatever and eat it. You'll get the same effect, but it'll be the cheaper way of doing it. But it's just a hassle, and frankly, older patients, meaning people like me, they don't want to do that. They're too nervous about doing that kind of thing. They want a pill or a capsule. It's easier to take, but that'll be a little bit more expensive. Yeah.
What are our expected outcomes on pain management? So yeah, it helps with pain, but we're looking at like 2-point decrease on that pain scale. Like what can we tell our patients to expect?
Good question, and I don't have a specific answer. It'd be nice if I did. If I was doing pain scales per se. My biggest measure for me personally is, are they stopping asking for increases in their opioids? So I'll tell you, I'm not giving you any more. You're as much as I will do, but I'd like to talk to you about using medical cannabis if you want. If they want to do that, and they'll try that, and then I'm going to say, how are you doing? Most time, they're doing great, and they don't need it. They're not even asking for any more pain pills. So it would be better scientifically if I was doing a pain scale where I could document, then I could publish something, huh? But if I have actually evidence, but I don't have that. I'm going by the patient's report. And as you know, with pain treatment, we're just trying to maintain functionality, right? And that's my other goal is how are you doing taking care of your kids and getting to the store and doing those things.
So, you said 113 grams of unprocessed flour. Is that 20 grams of THC, 30 grams, 10 grams, 5 grams?
Depends on the flour. Every flour bud is different. They're supposed to analyze that and tell you what's in it. But based on how that plant was grown, what plant it'll all be different.
So you buy the flour, it should tell you the quantity.
The label on the flour should tell you how many milligrams of THC and CBD are in that flour. It doesn't tell you about the other 118 other cannabinoids there, but they're more minor, although they do help you, but they're in there. But the big ones are the THC and CBD. That's what you want to know about. That's how you want to figure out what patients should have. Yeah.
What type of cost is there?
Oh, people are telling me that sometimes, $100, $200 a month to treat their pain or their, PTSD or their muscle spasm. Be pretty expensive. I keep hoping the cost will go down as we have more growers and less rapid growth in card holders, but we keep having lots of card holders and probably need more pharmacies to have more competition. So, but it's not the Utah system, which I think makes it very safe, controlled growing, controlled processing, independent lab testing. Those are really good things, but they raise the price. And then the pharmacies requiring a pharmacist to be on site at all times raises the cost. It's a great thing. It's better for patient care, but it makes it cost more. And they don't have the multiple products like other drugstores have where they can cover, costs with other drugs and things. It's just to have the cannabis products. So the biggest barrier is the cost.
Are we getting ourselves in trouble if we prescribe that for anxiety for off-label use, even patient swear by it that he or she will get off of benzodiazepine?
So first of all, we always talk about recommending cannabis. We never talk about prescribing it, right? We can't prescribe. We recommend cannabis. So do patients that I have use it off-label? The answer would be yes, but they only qualify it if they have one of these conditions. So I often have a patient with chronic pain, and the patient says, "Oh, Dr. Babitz, it's really helped me go to sleep at night." I say, "Great, you can get off your Ambien or whatever you were taking." But that's why, so I'm using it at nighttime too for that, so that's fine. Or, yeah, it's really helped my anxiety, for example. And I always will say, well, what kind of mixture are you using? I'm just curious to see what they're finding that works well for them. But the answer is yes. They have to qualify under these approved conditions. After that, up to the patient, right?
So you don't write it on a prescription pad, give it to them?
Nope. If I wanted to recommend a product, specifically, it goes in the EVS. So I have a patient who I've done all my exam and all the stuff done. They go into the system and register themselves. I go in the system to certify them, which means I put in their information, verify that's my patient, and I can approve them. Then I upload all that medical history and physical exam stuff to have that there. And then after I save that, which means the patient is now approved, they're now approved for cannabis. They're going to get a card. After they pay $15, they'll get their card electronically. Then there's a section that says recommendation. I have the option now of clicking on that and say, I recommend that they have X, Y, or Z. I have never used that. I have tremendous faith in the cannabis pharmacists, and so far, it's better. They're better trained than I am actually at understanding the different forms of cannabis and how it works at doing that. And I think they're probably better trained than 99% of physicians actually on cannabis. These cannabis pharmacists all have come from these big companies that have been doing cannabis for years. They work doing other states, work other places, so they're quite expert. I tell the patient what to expect. I tell the patient to go to the pharmacist and say, Dr. Babitz says I need a balanced product because otherwise I'm going to get high or I'm going to get not going to feel good. So I tell the patient what I suggest. I tell the patients about you want to try vaping initially, fine, but you got to try to move to an oral product and have the pharmacist help you with that. I'll talk about the different ways they can take it. So I'll give the patient a lot of advice about how I would recommend it, but I don't go in there and tell the pharmacist you have to do it this way or that way. Yeah, I can do that. Yeah, I can. Yeah. Yeah. The other thing I run into is why another reason I don't do it, my other excuse why I don't do it. Every pharmacy has different inventory. I have no idea what pharmacy A has against pharmacy B. And if a patient goes to pharmacy B, they may not have the product I was recommending for them. Then what do they do? Now I'm on the phone with the pharmacist, what to do. I don't have time for that. I'm not going to do that. The pharmacists, the ones I've met and talked to, I have great confidence in. They're well trained, they're well experienced, and I trust them. I give the patient the basic parameters they ought to use, and so far, again, knock on wood, but so far it's worked really well for me. Yeah.
I know a lot of providers are doing a cost base to get these cards, like $200 for your office visit to get the card. So I'm wondering, office visit as far as coverage by insurance versus independent.
So one of my biggest pet peeves with the passage of the cannabis law was the pop-up of strip mall cannabis card shops, where for $400 we'll get you a cannabis card. We're not your provider. We're not going to take care of you. We'll just give you a card, and you're on your way. And then come back in 6 months and pay $200, and we'll give you a renewal, right? I absolutely hate that. It's a ripoff because patients with these conditions that qualify, every one of those conditions is billable to insurance. I tell a patient, you're coming to me as a primary care doctor, and I'm not going to promise you a card when you walk in the door. I'm going to promise you an evaluation for whatever your problem is. And if we agree that cannabis may be an appropriate treatment for your chronic pain, your spasticity, whatever, then great, I'll be happy to recommend it for you. And guess what? Insurance is going to pay me for those diagnoses. I do not write diagnosis medical cannabis card, right? So my biggest pet peeve is the abuse of the system by these pop-up medical cannabis card clinics, if you call them, because they're not taking care of patients. We take care of patients. I'm there if they have other problems. I'm there if they have other questions about it, but not these clinics. So there shouldn't be a charge. And I think Rich was telling me the other day, so a big study was done, which is now published. Patients can go online and see who's charging how much for getting a card if they want to do some, shopping. I guess, yeah. Does who?
Yeah.
They can be, they usually hire nurse practitioners or PAs. That's the most common professional that's there. They hire them, and they have a controlled substance license. They can apply to be a QMP, take the study, and they pay them pretty good just to recommend cards. It's a whole new industry has sprung up. Yeah.
Yeah, and I just emphasize that there are, I think, concerns with some of the prescriptions for years that have been made by certain physicians and providers, right? And so that problem exists. Same problem exists within the medical cannabis recommendation world. There are recommendations that I think it's a little premature, and there's advertising that I think is a little predatory. But the Utah legislature has done a few things. One thing is they've created the medical cannabis cost website, where every single medical provider who's registered as a QMP has to self-report their price that they charge, and they must indicate whether they charge insurance or not. So patients go into that with at least one indication of what is going to be charged at that facility. Now, insurance, as you know, is tricky because sometimes it depends on the type of insurance they have, right? Whether they get that cost or not. But there are some clinics that do not bill insurance at all. At the beginning, there were clinics charging $400 or $500 for a visit, and it was frustrating. And for that reason, the legislature said, okay, let's create this website where patients can go to learn more if they choose to. But it still is buyer beware.
And that's
It's if you go to medicalcannabis.utah.gov, and if you go to providers, there's the provider tab. There'll be a link to, it's actually the state auditor's website, but we have a link to it because the state auditor helped us put that together. There's a geographic map that shows where QMPs are geographically located throughout Utah, and what their prices are and what their addresses are. And as you know, like 10, 12 providers can work under one clinic.
Let me finish. I'm going to just a few more slides. I've tried to go through. And a lot of these you've already asked about. People ask about dosing kind of thing. Always start with a low dose for people like any drug and then go from there. You want some ideas about the dosing for CBD and THC. CBD really, it's hard to hit a maximum. I have people taking 500 milligrams of CBD 3 times a day trying to get anxiety relief or sleep or whatever. They don't really have side effects. THC is the one you get the hyperemesis syndrome when you get too high a dose. So that's just some general things, but just for terms of dosing. Let's see. And then follow-up is important to see how they're doing. Like any medication you start people on. How's it working? Is it working for you? Going over drug interactions. Hyperemesis problem, probably taking too much THC. Important to know. And are they vaping since they shouldn't be vaping? Again, typical things you do that. With CBD, those are some typical symptoms to watch for. Some things about just patient safety things for initially till they really know how it's going to affect them. But most patients, they get used to I call it the side effects of maybe being a little sedated, and they do fine. They can go to work and they can do things. They can't have a CDL, but they can go to work and do activities. Aviation's the tough one, 28 days. Oh. Yeah, I know. I thought it was interesting. They were the toughest one to look at. Yeah, like Rich was saying, private employers have discretion. Public employers do not, based on the recent law change. So I thought this was interesting about CBD, a reason to try to buy CBD that's made, processed, certified in Utah, so you get a decent product because of these kind of things. Same thing with the THC. When people are looking at samples across the United States, they found these kind of findings, which is kind of disturbing, really. Not very accurate, but I think Utah has done a good job of regulating their products. Let's see. Urine testing, days to weeks, you can find cannabinoids. You probably all do urine testing if you have patients on opioids, for pain, and it'll come up on that. And then it's interesting, it'll stay in your mouth for a while unless you brush your teeth or gargle or whatever. Let's see. I always like to say it's not clear to treat everything. Like any other medication, you treat like any other medication, in my opinion. And back to Rich's website. This is where you get information. It's by calling the program office and talk to them. Rich can refer questions to me if you have questions that are more medical. He knows how to get hold of me, and he's welcome to send information to me if he wants.
Are we able to see these slides someplace else?
I think you get to have copies of them. I think the slides are given to you. Okay, yeah, I think you're going to get the whole thing. So, yeah. Anyway, I'm sorry to hope it didn't get too long. I guess we're just going to make it. Any other questions that people had? I'm sorry. Oh, yes, sir.
So what do you do with a patient who comes to you and says, well, I'd like a card. I use regularly, and I'm worried about my employer, doing a positive screen with my employer, and so I'd like a card. And
My first question is, what condition are you treating with your cannabis?
I hurt right here.
And how long have you had that pain? Yeah, it's more than 2 weeks, obviously, not very long. Say, well, so I need to understand why you have that problem. I need to make a diagnosis before I treat it. I mean, we don't treat pain without diagnoses, right? I'm going to send you off for an x-ray probably, maybe to go to the occupational therapist, have an evaluation. And if I find that you have a significant chronic condition with your little pinky that's important what you do and it causing pain, yeah, we can talk about cannabis as an alternative. There still are others like NSAIDs and things like that. So we can talk about it as a thing, but they don't walk in and get a card from me for that, no. Yeah. But they can walk into some of these little store box places and get one for $400.
I have had patients that told me that they were taking it for menstrual cramps, and I've followed up. Well, gosh, what oral contraceptives have you tried? What have you done? Oh, nothing. This is the first thing they have me try. Ankle sprain. Oh, have you had some imaging done? You seen orthopedist? No, I've had one X-ray and it just still hurts.
Menstrual cramps and ankle sprains are acute pain. And the literature, in my experience, says they do not work that well for people in that. It may get them to, by affecting their brain, they may not appreciate the problem as much, not so well. I worry about menstrual cramps with people because I'm talking about someone who is fertile And is this woman just using it only when she has her period, or is she using it like preventatively, right? She starts about a week before her period's supposed to come. Am I actually exposing a fetus to cannabis by giving it? So I don't do menstrual cramps. I don't do acute injuries like ankle sprains.
Another quick question on the last couple of slides is what's the safety data for work? I mean, you don't hear of people getting hurt all over in Colorado or places where it's used a lot more, but
Safety data is very good. I mean, it's better. You know, the cannabis advocates love to say you cannot die from cannabis. That's not quite true. There is no overdose of cannabis. There's no, the worst thing you'll get is horrible vomiting and spaced out. But people have died of cannabis because they've driven off the road. They've jumped off a third-floor balcony because they were so high that they didn't do that. So people who abuse cannabis, yeah, they can die from that. But in terms of adverse effects, if you don't have heart disease, if you don't have mental illness, if you don't have respiratory problems, then we just don't see adverse effects other than the mild things that make you stop. I get nauseated, I get diarrhea, so I'm just going to stop using it.
well, what if I'm a crane operator or a punch press operator, or I'm the safety check guy for the entire assembly line here that's 100 yards long? I mean, those are the kinds of questions that I get. Is that safe? Can they use those and be safe in those kinds of occupations?
The answer is I'm going to say it seems to be. So every individual will be able to have to decide how it's affecting him or her personally. Again, I like to have people start on a weekend. But for many people, once they get used to a dose, it doesn't bother them anymore. I mean, I would say the same thing's true of your gabapentin patients. When you first start, they get kind of drowsy and goofy, but then it gets used to it. Your opioid patients, same thing, they get used to it. I mean, so many other drugs that we give people, that's what we see. Their body gets tolerant to it in a way that you don't have the side effects. And it seems to be true with cannabis. So I haven't seen a problem with that with people. Now, I don't have safety inspectors that I know of in my patient population who are doing that. I don't have people driving commercial trucks or anything like that. I have people who work at an office, work at a desk. I have people who do housekeeping or things like that where they need to be pain-free to get their job done so they can function. Seem to do fine with that, so yeah.
The data is that that's pretty much true as long as you're doing something you're well accustomed to. But when you change it, they perform very poorly. The best study was they had professional racetrack drivers do the racetrack, then smoke, and did it backwards. And it was a disaster.
So the comment, I'll repeat, the comment was that when people are doing a regular job regularly and they get used to medicine, it's not so bad. But if they're using that medicine and they switch to a different activity, then there could be a problem.
You do very poorly.
Yeah, good point. Good point. Yeah. I would not give I wouldn't even give a card to them. If I had somebody who was on cannabis and needed a blood thinner, I'm going to immediately tell them to lower the dose of the cannabis, and I'm going to start on a really low dose of the blood thinner. And then I'll monitor their INR to see, where they are on that. Pardon? The issue, I'm going to warn them about the signs of serotonin syndrome. And again, I would probably lower their dose of cannabis first, and then consider lowering the dose of their antidepressant if necessary. Yeah, for the other, whatever the symptom they had. Yep, yeah. I don't think the antidepressant issue is a strong contraindication. I think the blood thinners are. Yeah. Sorry. Thank you.